Good evening, everyone. And on behalf of the ISN North Zone, it's indeed a great pleasure to invite all of you to this new academic exercise of having an online CPC. As Dr. Kher mentioned very rightly, that CPCs are always a great learning experience for clinicians as well as pathologists. And PGI has always had a great reputation for providing excellent CPCs, where CPCs are discussed by residents as well as faculty and in-house, as well as they provide the material for the national conferences, and proud about it. So this is the new initiative from the North Zone Forum, and I congratulate Dr. Raja for starting this, and I'm sure you'll all learn and enjoy the experience. Invite all of you, and I request Dr. Sapuja to carry on the proceedings. Sir, please.
Thank you, Dr. Bhaumik. It's a pleasure to be here with all of you this evening. I also welcome my co-chairpersons, Professor Vijay Kher, Professor Kusum Joshi, Professor Manoj Jain, and Professor Ritambra Nada. We'll get started right away with Dr. Aakanksha presenting the clinical protocol of this patient. I'll request all the speakers to stick to their time limits so that we can finish on time and have enough time for discussion. So over to Dr. Aakanksha, please.
Thank you, sir. Very good evening to respected faculty members and my dear colleagues. I'll be presenting the first half of today's clinical pathological correlation case, that is the clinical part of this. So before starting with the presenting complaints that this patient had, we have some relevant background information that I would like to share. So it was a 54-year-old gentleman who had presented outside somewhere 8 months prior with complaints of lower backache, which was radiating to bilateral lower limbs. It was evaluated subsequently, and an MRI of the lumbosacral spine showed that he had prolapsed intervertebral disc and bilateral neural foramina compromise was there. For this, he received epidural depomedrol injections. 2 doses were given 1 month apart. After the last dose, that is the second dose, 3 days later, he developed complete paraplegia. And it was noted that there was an abscess at the injection site. For this, he received some IV antibiotics and no further depomedrol injections were given to this patient. However, recovery could not be there and he remained bedbound and later developed a grade 2 bed sore. So over this period, over the 8 months, he remained bedbound and was at home, and then this is how he presented to us. So he came to us with the 1 month complaint of decreasing urine output, and towards the end, over the last 4 or 5 days, it was complete, almost complete anuria. He also had complaints of on and off fever, which would get relieved partly by oral antipyretics. However, it continued to persist. He then later developed complaints of altered mental sensorium over the last 10 to 12 days before presenting to PGI. And for these complaints, he had multiple admissions at other hospitals outside where he received IV antibiotics on and off. When he presented to PGI on examination, he appeared drowsy, disoriented, and dehydrated. He had tachycardia and tachypnea, was febrile, had pallor on examination, and bipedal edema was present. A bedsore was noted in the sacral region. Relevant CNS examination showed that there was decreased tone in bilateral lower limbs, and the power was 0/5. Reflexes were absent, and plantars were mute. Per abdomen examination revealed epigastric tenderness. Liver was felt 4 cm below costal margin. Spleen was felt 2 cm below costal margin. Rest of the examination was unremarkable. So with this information, the database that we get is a 54-year-old male patient who had a prolapsed intervertebral disc whether an intervention because of it led to eventually paraplegia in him. He was bedbound and had grade 2 bedsore. He was a non-diabetic otherwise and a non-hypertensive with no other chronic illness in the past. There is some history of alternative medicine intake for about one week, which duration and kind of medication is not known. He then had oliguria, fever, and altered sensorium, and examination revealed hepatosplenomegaly. So investigation-wise, he had some degree of metabolic acidosis, which was compensated at presentation, and he had some hyponatremia, which got corrected over the course of his hospital stay. He had kidney function derangement, creatinine at admission being 3.8 and going up to 8.1 towards the end of his hospital stay. He had anemia, leukocytosis, predominantly polymorphs, and he had thrombocytopenia, which improved over the course of his hospital stay, and he had evidence of coagulopathy. His liver functions were overall normal, but he had some hypoalbuminemia. Urine routine microscopic examination showed 3+ albuminuria. RBCs were there in the entire field. There were 10 to 15 pus cells per high power field. Infective workup, including blood culture, urine culture was sterile. Viral markers were not reactive. X-ray showed just evidence of bilateral mild pleural effusion. Ultrasound of the kidneys showed normal sized kidneys. There was some evidence of nephrolithiasis and mild hydronephrosis bilaterally. Liver and spleen were enlarged and no free fluid or ascites was noted. The patient also underwent a DVD scan in view of bipedal edema, which was normal. CT confirmed the findings of nephrolithiasis, and there was some evidence of nephrocalcinosis in the left kidney. An MRI brain was done because of the encephalopathy, which revealed some acute infarcts, and the etiology was probably embolic. With following this, the hospital course, so he was labeled as having AKI secondary to urinary catheter related urosepsis, for which he received broad spectrum IV antibiotics with us. And towards the end, he had worsening azotemia, had encephalopathy, metabolic acidosis, and hyperkalemia. So he was put on acute peritoneal dialysis. Subsequently, he developed hospital-acquired pneumonia, had respiratory failure, developed shock, and by day 5 of his admission, he had refractory septic shock and had a cardiopulmonary arrest, after which he could not be revived. So now, with this additional information, the database includes a 54-year-old male patient with paraplegia, oliguria and deranged kidney function, fever, worsening sensorium and hepatosplenomegaly. Investigations wise, he had some metabolic acidosis, anemia, thrombocytopenia, presence of coagulopathy, hypoalbuminemia, microhematuria, albuminuria, and some evidence of nephrolithiasis and hydronephrosis, with the neuroimaging showing infarcts, query embolic. He eventually developed hospital-acquired infection, sepsis, and refractory septic shock. Now, this brings us to the discussion. So for the paraplegia part, initially he had prolapsed intervertebral disc. However, and it is the most common cause of lumbosacral radiculopathy. However, developing complete paraplegia because of a prolapsed disc is very rare unless there is a rupture of the disc. So he mostly had another additional pathology that was leading to his complete paraplegic state. So additionally, most likely he had an untreated spinal epidural abscess that developed following that injection of dipomedrol, or there could be a hematoma, which can be seen sometimes after epidural injections leading to cord compression. Another possibility that comes to the mind is a pathological vertebral fracture, which could have happened considering other manifestations that this patient had. So whether it was a myeloma-related lytic lesion or metastasis because of some malignancy cannot be ruled out. Other remote possibilities could be vasculitis leading to spinal cord or nerve root infarction, presence of discitis or vertebral osteomyelitis, arachnoiditis leading to cord compression, and transverse myelitis related to certain vasculitis may also have been one of the etiologies. So this patient definitely had sepsis, but what was the likely focus in his case? So one possibility is definitely acute pyelonephritis. Points favoring the diagnosis of acute pyelonephritis are predisposing that the patient had predisposing factors in the form of doubtful querineurogenic bladder associated with that paraplegia. He had evidence of nephrolithiasis. He had a urinary catheter in situ for a long duration. Other evidence is the presence of significant kidney dysfunction and pus cells in the urine. Points that might not favor it so much is presence of significant albuminuria to the range of nephrotic state, and urine culture, although was sterile, but it cannot rule out the possibility of acute pyelonephritis. Second possibility is that the patient had an epidural abscess or a vertebral osteomyelitis, arachnoiditis, which was the focus of this entire sepsis. And points that favor it are the presence of a preceding procedure or an intervention that happened, and persistent paraplegia even prior to this illness. And in this case, we would attribute the renal dysfunction to a septic ATN kind of a pathology. Another focus of infection in this patient could have been an infected bed sore, as he had been bedridden for a prolonged period. And another etiology could have been infective endocarditis. We do not have the echocardiographic findings in this patient, and this patient had some embolic showers in the brain. So again, infective endocarditis could have been one of the possibilities for this sepsis. Now, causes for the kidney dysfunction per se in this patient, one would be AKI, the syndromic diagnosis of AKI, in which the etiology could be acute pyelonephritis. So points favoring again are the presence of risk factors, including the bedbound state and the presence of a catheter, having high-grade fever associated with chills and rigors, presence of pus cells in the urine, patient being normotensive to hypotensive throughout the course of his hospital stay, and eventually progressing to frank sepsis and septic shock. The only point that seems to be not favoring this is that the oliguria definitely preceded the onset of fever in this patient. And another possibility in this sepsis part is that the patient could have had any other focus of infection, and eventually it would have led to the septic ATN. The second possibility is that of an acute kidney disease or an RPRF-like presentation, or bordering a nephrotonephritic kind of a presentation. And the points that would favor it is presence of albuminuria, presence of microhematuria, advanced kidney dysfunction, patient being normotensive, and that the fact that oliguria preceded the fever onset. The pointer against would be that the patient did have high-grade fever associated with chills, which we may or may not expect in this situation. A third possibility is that the patient had an acute disorder, a kidney disorder, on an ongoing chronic kidney disease. So the chronic disease that we are thinking of is chronic interstitial nephritis. One, because the patient had some nephrolithiasis. We are not sure about the neurogenic bladder, and also that the duration is not enough perhaps to cause reflux nephropathy, but that could be a possibility lower down. And also this patient had some CAM intake history that could be contributing to it. And acute component over this would be the presence of pyelonephritis, a septic ATN, or per se any RPRF or AKD pathology. Now, differentials for our acute kidney disease or an RPRF presentation. One possibility would be an underlying glomerular disease, which would include either an immune-mediated glomerulonephritis or a POSI-immune one. And in the immune complex GN, our possibilities are infection-related GN and lupus nephritis predominantly. And in POSI-immune GN, ANCA vasculitis is the possibility. Another differential that we kept was whether this patient could have had an underlying atypical hemolytic uremic syndrome or a TTP. Points favoring would be presence of anemia, presence of renal dysfunction. This patient also had altered sensorium and fever. This patient had thrombocytopenia and it recovered, although it recovered spontaneously. The major pointer that does not favor this pathology is that the patient was normotensive throughout. With this vascular lesion, another vascular lesion that might be a very remote possibility is bilateral renal vein thrombosis, and the predisposing factors being that the patient was bedridden, had hypoalbuminemia and hematuria, but this possibility would be very remote and lower down. Our third possibility in this category was multiple myeloma or any other hematological malignancy. And the points that favored it was the presence of fever of a long duration, presence of hepatosplenomegaly in this patient. And in the CRAB criteria, the patient had at least two of the criteria being fulfilled, that is renal dysfunction and presence of anemia. And whether that lower back pain and paraplegia could have been because of certain lytic lesions that may have been in this patient, although there is an MRI that does not reveal any such lesions. However, this MRI was done 8 months prior, and we do not have the exact findings also or the imaging available right now. In the glomerulonephritis part, so points favoring infection-related glomerulonephritis are that the patient had a history of cutaneous infection at the site of the depometrol injection. Presence of significant albuminuria and microhematuria are other pointers towards IRGN. Then another possibility could be lupus nephritis in the presence of albuminuria, microhematuria, prolonged duration of fever, presence of altered sensorium, which may be explained by CNS vasculitis. But again, there are pointers that do not favor it, which include which do not completely eliminate this as the etiology, but make it less likely. That is, it was an older male patient, and there did not seem to be other systemic manifestations of SLE in this patient. Our third possibility is that of ANCA-associated vasculitis in the light of microhematuria and advanced kidney dysfunction with altered sensorium, again could be attributed to CNS vasculitis. Presence of peripheral neuropathy and nerve root infarction, although rarely, can lead to paraplegia in patients with ANCA vasculitis. And presence of thrombocytopenia is again a pointer that may not be favoring ANCA vasculitis. For the encephalopathy part, first etiology, the first likely pathology that we thought of was septic encephalopathy. Whether this was septic encephalopathy per se or a septic emboli shower going from an infective endocarditis focus is remains to be seen, but the patient did have a prolonged history of fever, so this could be one of the reasons. Then presence of unemic encephalopathy, at least partially contributing to the encephalopathy, could be there, as the patient had advanced azotemia and had urea values of more than 300, at least towards the end of his illness. Then another pathology could be CNS vasculitis, as we have seen that the neuroimaging showed multiple small areas of infarcts, and in the background of renal dysfunction, vasculitis can be a possibility. Arachnoiditis leading to meningoencephalitis because of the preceding history of that procedure or intervention that he underwent. And lower down, we had kept possibilities of TTP leading to encephalopathy. However, there was no evidence of ongoing hemolysis, and the thrombocytopenia part also resolved, so this seemed unlikely. And cerebrovascular accident also lower down, although the neuroimaging did not show any evidence of such an event, but in the presence of coagulopathy, it could have been a possibility. The patient also had anemia, which would be partly contributed by his nutritional intake, which was very poor, which would have been poor because he was in a bedbound state, and intake may not have been very good, and could have been contributed by intravascular hemolysis, sepsis per se, and the kidney disease would have contributed to this anemia. So this is a table that has clubbed all the possible etiologies of likely etiologies in this case. So our first and foremost possibility was acute pyelonephritis. and it does fit in or corroborate with the presence of fever, having encephalopathy, which is septic encephalopathy secondary to urosepsis. Presence of hepatomegaly and the background of sepsis can also be explained, and anemia, thrombocytopenia, presence of, although albuminuria might be a little disproportionate to the what we would expect in a patient with acute pyelonephritis. Even then, this seems to be a good or one of the more favorable etiologies that might have been there. Another possibility that is there is septic ATN, which could have been either an AKI-like event or an acute on chronic kind of a kidney disease. And since the patient had fever, patient also had encephalopathy, hepatosplenomegaly, anemia, thrombocytopenia. Again, the degree of albuminuria may not correspond to this illness. So even then, it seems like a likely possibility. Third possibility being infection-related glomerulonephritis. So yes, fever can extend and may be present beyond the period of initial period, and and this degree of albuminuria can be explained. So yes, this can also be one of the possibilities. Coming to ANCA vasculitis, so we may be able to explain the paraplegia part also by ANCA vasculitis, and again fever and encephalopathy may also be explained. However, presence of hepatosplenomegaly, thrombocytopenia, and the significant albuminuria may not be completely explained. Coming to SLE with lupus nephritis, again, partly we may be able to explain by some remote etiology the paraplegia part, but fever with encephalopathy, hepatosplenomegaly, presence of anemia, thrombocytopenia, and albuminuria all correspond, can be explained nicely with the lupus nephritis, except for the fact that this patient's age and gender may not completely fit the classical case of SLE. Then TMA would explain the presence of fever, encephalopathy, anemia, and thrombocytopenia. Again, this albuminuria may not be explained, and BP records have been persistently normal, which is a major pointer against this TMA. Coming to multiple myeloma or any other hematological malignancy, again, we'll be able to bring in this initial part of paraplegia into consideration, and again, along with fever, hepatosplenomegaly, anemia, thrombocytopenia, albuminuria, this might be a possibility. However, we had two of the criterias getting fulfilled, and we have an MRI which does not show a presence of lytic lesions in the beginning. So in this patient, towards the end, this patient had acquired a hospital-acquired infection and pneumonia, which could have been bacterial because the patient was bed-bound and had risk of aspiration. Then fungal is also a good possibility in this patient because he had previous multiple admissions, has received IV antibiotics, was not responding, and had a very had a rapid deterioration. Or it could very well be a combination of bacterial and fungal pneumonia. Viral, however, would be less likely. Then there was eventually rapid worsening of sepsis and progressing to refractory septic shock. The patient could have had a DVT, although there was a DVT scan done in the beginning which did not show any evidence of deep vein thrombosis. But again, towards the end, it cannot be ruled out that the patient may have had a pulmonary thromboembolism. Other possibilities of the demise could have been an arrhythmia, acute coronary event, or a cerebrovascular accident, and these cannot be ruled out. However, I would like to keep them lower down as a possibility. So the final diagnosis in our patient is paraplegia, for which the possibility most likely would be a prolapsed intervertebral disc with an epidural abscess. For the renal dysfunction, our syndromic diagnosis is acute kidney disease, more likely than acute kidney injury or acute on chronic disease. And amongst the etiologies, acute pyelonephritis would be more likely than glomerulonephritis or a paraproteinemia, and we would like to keep TTP or HUS lower down. For the fever and sepsis part, pyelonephritis would most likely be the focus of infection followed by infective endocarditis, while these constitutional symptoms may also be explained by vasculitis or a malignancy. For the encephalopathy part, it is more likely that the patient had a septic encephalopathy or a meningoencephalitis with contribution from this uremic encephalopathy as well as those CNS infarcts that we saw. Anemia could be because of predominantly nutritional and as well as because of the chronic illness. And thrombocytopenia is more likely to be explained by the ongoing disseminated intravascular coagulation. Hospital-acquired pneumonia could have been bacterial, fungal, or a combination of both. And the terminal event is most likely a refractory septic shock. However, possibilities of pulmonary thromboembolism and acute coronary syndrome or an arrhythmia cannot be ruled out. Thank you.
Thank you very much, Dr. Aakanksha, for a comprehensive discussion of all the manifestations with which this patient presented. Of course, you've cast your net relatively wide to cover all the possible connections between his illness and the kidney problem. The clinical protocol is now open for comments to the entire audience, so everybody is welcome to give their comments or put them in the chat box.
Aakanksha, can you please unshare your screen?
Yes.
Yeah. Fine. I just have a few general comments. One is, of course, ANA, ANCA, etc. C34 is not available. That has been mentioned by Raja. The urine showed, I think, micromaturia and 3+ albumin. Patient was catheterized, I think. I mean, we are not sure whether the micromaturia is because of the catheter or whether it is a glomerular maturia. So maybe it would have helped if we had finding whether it is morphic or it was isomorphic RBC. That may have helped short of
Right. That is right, sir.
Sorry?
Yes, sir. We were also deliberating whether it would.
Yes. So that is one. And of course, I'll also say that, when you have a lot of RBC in the urine, up to 2+ albumin can be present. So, I mean, it can be explained on the basis of either the catheter or maybe it is a septic GN due to IRGN, I mean, it's a maturia.
Was that?
I think, Vinay, can I say something? I think
Sure.
I would expect the diagnosis to be glomerular disease than a pyelonephritis. I agree with Aakanksha's good discussion on all the findings in this patient, and I agree that all these possibilities are there. But first, CPC, I don't think I would expect to see acute tubular necrosis. I don't expect pathologists to show me acute pyelonephritis. I would feel that probably glomerulonephritis, and I would feel maybe an infection-related glomerulonephritis. I wouldn't be surprised if they show me infective endocarditis.
Endocarditis, yes.
And I think my suspicion would be that I would expect to see endocarditis and endocarditis-related infection and infection-related glomerulonephritis. That would be one. I wouldn't be surprised if this turns out to be an ANCA-associated vasculitis as well. And I think my third possibility probably would be a multiple myeloma or a malignancy. So these are three of my sort of take on this. It is, I agree, Aakanksha, with your discussion. My age and my seniority and knowing the PGI CPC backgrounds, I would probably not expect to see acute tubular necrosis and not expect to see acute pyelonephritis. That's what my guess would be. So using these kind of modalities also, that's why my list becomes a bit different than what's yours.
Just one comment, sir. I mean, I was just wondering, patient had some septic emboli, I think, in the CNS. So it's possible sometimes these drugs can get injected intra-arterially. That's why actually FDA does not allow epidural injections, nor does the UK allow. So I was wondering whether, some sort of emboli would have gone into the kidney and caused some sort of initially focal ACN and then which has progressed. So that could also be a possibility, emboli into the renal artery. She mentioned RVT, of course, but I was thinking about the arterial part as well, ACN.
Yes, anybody else would like to comment before we go on to the
for myeloma, some
findings?
For myeloma, some workup was done, albumin globulin ratio or something more was done.
We don't have the
No, I don't think you have no details on any of those. So I think you have to make a clinical guess.
Okay.
Yeah, I don't think any workup was done for myeloma, the electrophoresis or the free light chain assay or anything like that. I don't think. And since an MRI was done at the beginning, at least the MRI probably did not show any bone lesions. That's all we can say. We don't have a skeletal survey.
Another remote possibility, PSA was done some maybe because patient had obstructive symptoms and anuria. So PSA was done or some workup was available or not?
No, again, not available, I think.
a few comments in the chat box, like somebody can take it up. Or shall I quickly read them, like, in a minute?
Yes, please do.
So I think among the people who have kept a diagnosis, I wouldn't tell the name, but like, there is one who says there is hepatosplenomegaly with 3+ proteinuria, so more inclined towards paraproteinemia. So other says a strong possibility of myeloma. Then the third is the presence of renal stone disease with nephrocalcinosis not explained with given possibilities. Then the next differential diagnosis is IRGN. So the other one is he says it could be an infiltration malignancies. Because of malignant infiltration, there is presence of hepatosplenomegaly. Then the next is infective endocarditis associated embolic cerebral infarct and infection related immune complex related glomerulonephritis. Other is IRGN. Then the other panelist says, could this be candidemia fungal endocarditis with fungal pyelonephritis? Then the other is stone disease and nephrocalcinosis suggest hypercalciuria. Could this be related to prolonged bed rest? So yes. Then other says infective endocarditis related disease. Then the last one is prolonged immobilization, nephrocalcinosis, obstructive uropathy, pyelonephritis will be associated with the component of meningitis. So these are the chats.
Yeah, so we have a very wide range of possibilities, and it's really difficult to narrow down the list. But I would tend to agree with what Dr. Kher suggested. I would go along with the possibilities in the order that he suggested. And if there are no more comments from the audience, then I think we'll go on to the pathology presentation, which is to be done by Dr. Rashmi from the Department of Pathology, PGI Chandigarh. Dr. Rashmi, please.
Thank you, sir. So is my PPT visible?
Yes.
Yes.
So without much delay, I would like to continue with the pathological protocol of this case. So this was a 54-year male, and he had nearly 6 days of hospital stay in PGI, and had a clinical diagnosis of septic shock, acute renal failure. Had a clinical diagnosis of septic shock, acute renal failure, nephrolithiasis, and encephalopathy, which was queried due to septic or infection related. So a partial autopsy was performed, and at the time of autopsy, prosectors noted that the serous cavities were within normal limit. So moving on to the organ complex of interest, that is bilateral kidneys, bilateral ureters, abdominal aorta, and inferior vena cava. We could see that the outer surface of the capsule, outer surface of the kidneys were smooth and the capsule was easily stripped off. However, it shows a lot of these hemorrhagic discoloration. Here also we can appreciate these hemorrhagic discoloration, which were obviously more on the right side. However, we can see the abdominal aorta was clean and did not show presence of any atherosclerotic plaques, and all the opening to all the major vessels were also clean. So this is a closer look where we can appreciate these hemorrhagic discolorations or hemorrhagic areas on the right side, as well as small pinpoint hemorrhages on the left side. On the cut surface, there was indistinct cortico-medullary, indistinct cortico and medullary. There was the cortico-medullary distinction was not proper, and we could see there was again hemorrhagic discoloration of the cortex as well as the medulla, and here the congestion was more in the medullary region, and the pelvic calyceal system was ulcerated and shows this kind of hemorrhages. And at the time of autopsy, the prospectors also noted a small yellowish stones within the pelvic calyceal system. And they also noted the stones within the ureter, and which caused ulceration of the ureter as well as this yellowish slough. The renal artery and the vein were also dissected, and however did not find any thrombus or any occlusion or stenosis. So moving on to the microscopy, in kidney generally we see the microscopy in 4 different compartments, that is the glomeruli, tubulo-interstitial compartment, and the vascular compartment. So at this power, at the low magnificent, we can see that the glomeruli apparently look normal, and the tubules also look preserved, and there was no significant atrophy. However, the interstitium was very busy and shows presence of this and was very busy and showed infiltration by these large blue cells. On higher power, again, we can see that the glomeruli apparently look normal. However, the peritubular capillary showed presence of these large atypical lymphoid cells, and these atypical lymphoid cells were confined to the capillaries and did not show any tissue infiltration. And in addition, we can see the tubules did not show any atrophy. However, there was marked acute tubular injury along with interstitial edema. This is a higher power showing. The glomeruli at lower power though looked normal, and they did not show any proliferative lesions or any segmental sclerosis or basement membrane thickening. But within this capillary loops, we can again appreciate these large atypical lymphoid cells, though they were very occasional in the glomeruli. However, here we can see all the capillaries were clogged with these large atypical lymphoid cells. This is again a more closer or higher power where we can appreciate this large atypical lymphoid cells within the capillary lumen of the glomeruli. This is another glomeruli showing similar findings. The section taken from the medullary also showed the medullary capillaries were completely clogged with these atypical lymphoid cells. And again, we can see that there were no tissue infiltration or the parenchymal infiltration. They were present only within the capillaries. So looking at these cells, they were very large, around 2 to 3 times, yeah, even 4 times the size of mature lymphocyte. They had regular to irregular nuclear membrane, coarse chromatin, prominent nucleoli, and scant cytoplasm. So with these findings, we can tell that there was a lymphomatous process going on in the kidney, and it was confined to the capillaries or only the vascular compartment. So this is a panel of photograph where showing involvement of these capillaries from various parts of the kidney by these atypical lymphoid cells, and occasional mitosis was also noted within these cells. The capillaries in the perinephric fat also showed presence of these large atypical cells, and however, they were again not showing any infiltration into adjacent tissue. So to categorize these atypical lymphoid cells, IHC was performed. And as we can see, CD20 was strongly positive in these cells. CD20 being a B cell marker indicated that these cells were of B cell origin. Here again, we can appreciate that these cells were strongly positive, showed strong cytoplasmic and membranous positivity for CD20. This is again a more higher power showing strong positivity, strong cytoplasmic membranous positivity for CD20. CD79A, another B cell marker, was also positive in all these cells. And here it was also highlighting the presence of these atypical cells within the capillary lumen of the glomeruli. This is the higher power showing same findings. Here we can appreciate these large atypical cells within the capillary lumen, which are positive for CD79A. CD3 was negative in these atypical cells and highlighted few scattered mature T cells in the background. And here we can see all these, majority of these cells were negative for CD3 and only occasional background T cells were positive. And the MPO performed was negative in these atypical cells. However, occasional neutrophils that were admixed were positive for this. So with this, what pathology that we are able to see in the kidney is there is an intravenous large B cell lymphoma that was affecting the kidney. Further, we also tried to take sections from the pelvic alical system, and we noted that there were presence of these crystalline substances on in the pelvis, which suggests that there was stones, and along with that, there was ulceration of this lining epithelium, and the subepithelium was showing dense neutrophilic rich inflammation with microabscess formation. This is again higher power, showing these crystalline structures, which are the stones present in the pelvic alical system. This lining is ulcerated and shows microabscess within the wall. So this inflammation was again ascending upwards to the medulla and cortex and forming multiple microabscesses of neutrophils. And these are again another section showing abscess within the cortex. Here another large neutrophilic abscesses, which is destroying the tubules as well as the glomeruli. And on higher power, we can appreciate it was predominantly of neutrophils and few nuclear debris, indicating along with nephrolithiasis. So these neutrophilic abscesses or inflammatory cells also were infiltrating the glomeruli as well as they were also present within the tubules. So in kidney, the patient had lymphoma, which was only confined to the vessels, and also a patient had nephrolithiasis and acute pyelonephritis. So moving on to the other organ system, this is an organ complex comprising of slice of liver, gallbladder, C-loop of duodenum, pancreas, and spleen. The liver was grossly weighing 1,460 grams and grossly did not show any significant pathology. The capsule was smooth. There were no nodules or any space occupying lesions. However, the spleen was enlarged and was weighing 465 grams. The capsule of the spleen was wrinkled, and the cut surface was congested, and the spleen was enlarged. However, its shape was maintained. So this section taken from the spleen showed here, usually when we see a spleen, it has a red pulp and the white pulp, and usually the red pulp will have a lot of RBCs and will look very red. But here the distinction was reduced due to presence of these large atypical lymphoid cells, which was occupying the sinuses. So on higher power, we can see the sinuses were filled with these large atypical lymphoid cells, and again, they were not infiltrating into the adjacent tissue. This is a high power view, again showing these large atypical lymphoid cells confined to the capillaries. And however, few areas show preserved white pulp where there were mature T and B cells around the central artery. So moving on to the liver, as I already said, grossly did not show any pathology. Even on microscopy, the lobular architecture of the liver was maintained. There was no increase in fibrosis. The single cord pattern of the hepatocytes was appreciated. Here again, we can see the portal graft had no increase in fibrosis or any inflammation. However, we can see the sinusoids were dilated and showed presence of these atypical cells within the sinusoids. This is again a high power view showing presence of these large atypical cells within the sinusoids of the liver. The portal tracts also did not show any significant inflammation or increased fibrosis. However, occasional capillaries present in the portal tract also showed presence of these large atypical cells. So moving on to organ complex comprising of trachea, bilateral bronchus, and bilateral lobes of lung. Bilateral lobes of lung weighed 950 grams together. The pleural aspect was shiny, did not show any fibrinous stacks. But however, the lung was subcrepitant to feel, and some areas extruded frothy material on palpation. Also, the tracheobronchial tree was unremarkable, did not show any ulceration or any aspirated material. However, the pulmonary artery was showing a thromboembolism, and unfortunately, I don't have that photograph here. The cut surface also did not show any cavitated lesion or space occupying lesions, but however, we can see there was a lot of congestion, especially in the peripheral regions. So the micro photograph from the representative section from the lung showed alveolated lung parenchyma. However, the interalveolar septa were congested and showed presence of these large atypical cells within the capillaries. Again, this is another view showing presence of these atypical lymphocytes within the capillaries. We can notice that the alveolar spaces are absolutely empty and do not show presence of these atypical lymphocytes. This is a larger view, high power view, again showing presence of these atypical cells within the interalveolar septa, within the capillaries of the interalveolar septa. This is again another hyperview showing similar findings. In addition, some of the areas in the lung also showed presence of pulmonary edema. And this is a section from the pulmonary artery which showed presence of a large thrombus, which was occluding it. So in view of this, we again took multiple, this other organs were also analyzed to see which all organs were infiltrated by these atypical lymphoid cells. And this is the section from the adrenal, which again showed presence of these atypical lymphoid cells within these capillaries. And however, the parenchyma was not infiltrated. This is again high power view showing same findings. Here within the capillaries, we can see the atypical cells. The skeletal muscle examined also showed presence of these atypical cells within the capillaries. And this was a section from the testis. Here also occasional capillaries show presence of atypical cells. However, the rest of the parenchyma was normal. And further, the bone marrow was analyzed. However, bone marrow was free of tumor and did not show presence of any atypical cells. And it was showing trilineage hematopoiesis and was normocellular for age. The heart was grossly unremarkable. The inflow, the right inflow, the right outflow, and the left inflow and the left outflow was unremarkable and did not show any significant pathology. The section taken from heart also did not show any significant changes. The section from the esophagus, stomach, large intestine, small intestine were grossly and microscopically unremarkable and did not show involvement by this lymphomatous process. So my final autopsy diagnosis in this case is intravascular large B-cell lymphoma involving both kidneys, lungs, spleen, adrenal, and liver. And there was acute pyelonephritis with abscess formation in the renal parenchyma in background of excessive nephrolithiasis. I've also not mentioned here, but there was pulmonary thromboembolism and pulmonary edema. So to give us some, to talk about some brief introduction about, to tell some few points about intravascular large B-cell lymphoma. It is a subset of diffuse large B-cell lymphoma, and it is intravascular proliferation of clonal lymphocytes with little to no involvement of the organ parenchyma. So universally, it has a poor prognosis, but if diagnosed early, remission can be achieved. So now the WHO says there are 3 variants, that is classical, cutaneous, and hemophagocytic syndrome associated. The cutaneous has a better prognosis because it is only involving the skin, whereas hemophagocytic syndrome is associated with hemophagocytosis and has the worst prognosis and is more common in the Asian countries. So usually these large intravascular large B-cell lymphomas, they present with non-specific features. They are diagnosed usually at the autopsy, or they're usually misdiagnosed. But this was a trend of past. Now, due to awareness of this condition, the clinicians are able to diagnose at ante-mortem in at least 80% of the cases. Here, characteristically, it is confined to the intravascular spaces like venules, capillaries, and arterioles, but not large arteries and veins. And the extranodal organs like kidneys, lungs, brain, spinal cord, skin, and other organs are also involved. However, lymph nodes, spleen, peripheral blood, and bone marrow are generally spared. So this is one case report that was published in Internal Medicine, where they had done a review of all the case reports that were published in the past. And they had collected a cases of 41 cases were collected among which showed renal involvement by intravascular large B-cell lymphoma. So among these 41 cases, they saw 25 cases had renal failure in the form of rise in creatinine. And however, proteinuria was more commonly seen. It was seen in 36 cases, and among them 10 cases also showed nephrotic range proteinuria. And when they tried to analyze what was the cause for this proteinuria, they saw minimal change disease was the most common condition that was associated with this disease. And they saw there were no findings on the light microscopy. However, on EM, they saw there was a lot of podocyte effacement. So the renal involvement in intravascular large B-cell lymphoma should be suspected when renal failure or proteinuria or nephromegaly are present. And in case of doubt, even PET-CT fusion images can strongly contribute to an early diagnosis and prompt treatment. And always renal biopsy can be very diagnostic. So what is the pathogenesis of intravascular large B-cell lymphoma? It is called neoplasm of Holmes. because it has an aberrant expression of CD11A or CD49D. Both are these required for binding. These both are integrins which are required for binding of these cells to the endothelium and helps in transmigration. So whenever they're aberrant or absent, there won't be any transmigration, and hence these cells are confined to the vascular spaces. IVL also lacks CD29, which is beta integrin, or CD54, which is ICAM1. Both of these are also essential for lymphocyte homing and transvascular migration. So before I conclude, I would like to I would like to thank Professor Ashim Das sir, who was this originally case belonged to him. And I also like to thank Ritamra ma'am and Raja Ramchandran sir for giving me this opportunity to be a part of this clinico-pathological seminar. Thank you.
Thank you, Dr. Rashmi.
Yes.
So I'm sure everyone is quite surprised at the pathology presentation showing an intravascular lymphoma. In the clinical discussion, it was dominated by infection, and in, say, infection-related glomerulonephritis or infective endocarditis, again, a consequence of bacterial sepsis. Whereas what has turned up in the autopsy is something that we did not expect at all. And of course, it was difficult to diagnose. This is a rare entity that you have shown us. So it won't have been easy to make a diagnosis of this ante-mortem.
Yes.
This patient didn't give the clinicians enough time, so it wasn't possible for a kidney biopsy to be done. He deteriorated fairly rapidly after admission. So with that, I'll open the discussion to everybody, to all the audience and panelists. Their comments and questions are welcome.
Dr. Rashmi, Mohammed, you go ahead.
Please, I just had one question to Dr. Rashmi, that apart from kidney biopsy in that study, what are the other possible tests which a clinician can do to diagnose it ante-mortem?
Sir, actually, skin involvement is also very common in these cases, and they usually present with skin lesions, and skin biopsy can be done. But in this particular case, there were no skin lesions.
Yeah, apart from this, any other test investigations which can help to make ante-mortem diagnosis?
He mentioned PET-CT.
Yes, PET-CT can be useful. But again, biopsy is only diagnostic, and skin either skin or the organ which is involved, in biopsy of that organ or skin biopsy can be diagnostic.
Can I make a comment here?
Yes, Dr. Ritamra. Yes.
In this context, latest literature has documented role of FDG PET in picking up these kind of intravascular lymphomas. The latest articles which she was quoting, there some of the cases were picked up on FDG PET rather than on CT scan. So that is another modality which can be used. There a diffuse uptake with rhinomegaly, mainly patients with pyrexia of unknown origin. That was a setting, and those cases when biopsy did show presence of intravascular lymphoma.
Dr. Rashmi, would you think that this spinal lesion that this patient had could be explained by this lymphoma, or you think that that was not related to this disease? What's the likely? I don't think you got to examine the spine as far as autopsy, but what do you think? And maybe Dr. Ritamra, I would ask you if you read anything about it.
So most likely, since this intravascular lymphoma is supposed to restrict within the intravascular spaces, and there was a mass in that paravertebral area causing that collapse. So most likely that might be related to the abscess or some infective etiology. This lymphoma does not go out of the vessels, so unlikely to form masses and cause that kind of a destruction. So since we don't have tissue diagnosis, but going by the nature of this lymphoma, we don't expect this to move out and kind of cause lytic destruction of those vertebral spaces. Maybe Ma'am Joshi can supplement what I've said. whether I'm right or wrong, but this is my assumption.
Dr. Mahesh here.
Yeah. Dr. Mahesh is our special invitee for the day. Like,
So this is a very nice case of the postmortem intravascular B-cell lymphoma case affecting multiple organs. I have been fortunate to see 3 cases ante-mortem. First is when I moved from PJ to Manipal Hospital in 2007, and that happened. So happened. All these 3 are were not picked up by clinical as there were no clues. And the first case was when a lady who happened to deliver by cesarean, and then the surgeons felt that it was bleeding profusely, so they ended up taking the uterus as well after the C-section. And when the uterus had come to us, the vascular system had very peculiar endothelial cells. If we look at the literature, the earlier literature of this entity, it is kind of labeled as hyperendotheliosis, the way different terminologies. And I sat for days together, and just out of curiosity, by exclusion of all other things, we did the immunohistochemistry, and that turned out to be B-cell positive. And bone marrow was done, like how the literature of this IV BCL, bone marrow is negative, and there was no other system involvement in that lady. That was the first case which I have seen in the ante-mortem. And once in the US, while in Cedar Sinai, I got the renal biopsy, which was very characteristic of glomerular lymphoid, enlarged ones which are filling up the capillary lumen. That was the renal biopsy first when I saw that. And coming back here, in Manipal Hospital, 2 renal biopsies which were acute kidney, one in peritubular capillaries, just floating in the peritubular capillaries. The recent one is the glomerular, which has appeared in the KI image section, which is the same typical what Dr. Rashmi had shown, that the abnormal lymphoid cells filling up the capillary lumens. So in total, 3 in Manipal Hospital, 1 in US. So all this, as the organ affected is more of a kidney, and the dermatology, the pathologists who are looking after these organs would come up with this finding, and then go back to the clinical or the clinician to do the certain tests. LDH would be elevated in this, but none of the other tissue invasion factors like lymph node or the bone marrow, everything be negative. And that's the pathogenesis of this being aberrant in the endothelial surface, being deficient in the CD11A. So that's my experience about ante-mortem diagnosis. And the frequency of it is, it's a periodical. Every 5 years in the Manipal Hospital, in the last 15 years, I have 3 cases, 2013, 2016. So it's quite rare.
In temporal sequence, if we see, this disc prolapse occurred 8 months earlier. So that time this disease was not probably, because this aggressive intravascular lymphoma, so it developed later on. That's what I presume. And that was altogether different pathology. So am I right, or I guess is right, my guess?
Looks like so. Any other comments? Any more comments from pathology? Dr. Kusum Joshi, would you like to comment?
Yes, well, I think had this patient not had the disc prolapse and complicated by the abscess, maybe it could have been picked up during life, because it does, the albuminuria, all these things are there. And then it's going to be a biopsy diagnosis, whether of the skin or the kidney or maximum of the liver. So liver enlargement renal enlargement with this kind of a lesion, unexplained sort of acute injury because of the vascular compartment being more or less blocked. I remember this case. This is the only one that we had seen a long time when Ashandas, worked it up for the CPC. Yes, it's a lovely case, a treat for all of us. And I still remember the discussion after that, it could have been picked up had it not had that complication of that abscess, and perhaps had the patient, gone to a Manipal hospital rather than to sort of local, physicians in and around Punjab. Yes, it's a treat for the pathologists to see this.
Yeah, I know.
Rashmi
Yes.
demonstrated it very
Adding
well.
to the prognosis of these three antemortemly diagnosed, it's quite fatal. In the first lady, it never crossed 6 months in all of these three patients. The fatality is that aggressive.
Even at autopsy, we've had only 2 cases of intravascular lymphomas, though our autopsy number currently is running into 30,500 something. So it's pretty rare. And as Mahisha said, it started crop. So these two also came back to back. One number was, this is 21949, other one was 21951. After that, we haven't had any other case. So we have learned how to pick it up. So it is also mentioned that lymphomas involve kidney infrequently, but at autopsy, generally 30% of them autopsy series shows that 1/3 of them tend to have renal involvement also. And CT scan and all picks up in about 3 to 4% of these lymphomas. Most commonly, lymphoma would be involved in the kidney involvement in an extranodal manner would be mantle cell lymphomas. So, which is also a part of DLPC. It's a variant of DLPC only. We do see, but it's not intravascular lymphomas.
Any other last minute comments? Dr. Raja, anything you would like to add?
Raja, you're muted. Dr. Grishnayan wants to say something, sir. Dr. Grishnayan, please. Then Raja can say after that.
Can I join in?
Yes, sir.
Yes.
You are in already in.
Yeah, no, because I distinctly remember these. There were 2 cases presented by PGI in the CPC. First was in our ISN written in the chat box also. Probably this could have been the case which was discussed in 2009 ISN con.
Yes, sir.
But last year, during the COVID times, I happened to attend a CPC from PGI. There was a case with cervical cord involvement, infiltrations into the cervical cord, probably a very infiltrating leukemia. Patient presenting with quadriparesis, and then it was something like a tumor. It did not present straight away as a quadriparesis, not acute onset, but gradually one after the other, the limbs got affected. And on autopsy, it turned out to be a infiltrating, if I'm not wrong, it was a leukemia which was presenting. So this very rare presentation of hematological malignancies. Could it be that there's lymphomatic infiltrations has involved the spinal artery and which has caused this paraplegia? Did we have an opportunity to dissect the spinal cord or see the?
So consent for that was not available.
Yes. So that was not looked at.
Yes. The second case which sir is mentioning was done by Dr. Bishan Radotra during COVID times, and that patient had cerebral, it was mainly a neurological manifestation where intravascular B-cell lymphoma was again shown, mainly affecting the brain. And so that was third case. So now I can recall that that was also intravascular lymphoma with mainly a neurological manifestation.
I think one thing is important, that lymphoma otherwise can directly infiltrate into the kidney, and that's much more commoner
Yes, sir.
and many cases have been written about and talked about. That's not an uncommon. But intravascular lymphoma, which is not infiltrating into the kidney itself, by itself is a rare kind of a tumor, and obviously is not the same as lymphoma infiltrating into, which could be a T cell or a B cell lymphoma, which can infiltrate into the kidney and cause acute kidney injury and acute renal failure as well.
Exactly.
In this
And I-
brain autopsy was not done in this.
Yeah.
So
No,
infarction
no.
was there, so that may be due to this lymphomatous part in the brain also.
Yeah.
That was not documented, I think.
Yeah, that's possible.
There is a comment. I'll just quickly read the comment as a post. How come these abnormal lymphocytes are not picked up on a peripheral smear examination? So
They don't come out in peripheral blood.
yes, it's
They
only
tend to just home within the blood vessels because the receptors in the blood vessels don't let them go out. So that is the reason they are not seen in peripheral blood.
are known predisposing factor linked to the disease. Any known risk factors linked to the intravascular lymphoma?
Not really. EBV people have tried, and which has been documented to be negative. It is not associated with EBV, which is one of the viruses associated with lymphomas. But whatever people series we have seen, when done, it has been negative.
And Dr. Dharmendra
Yeah.
says abscess and pyelonephritis seems to be part of poor immunity due to lymphoma, the renal abscess and the pyelonephritis. Yes, could be. So
Agree.
yes, these are the comments. And another comment is tubular dysfunction, nephrocalcinosis may have been ongoing for a while. So it's difficult. So it's obviously, I don't think that's the cause of kidney function in this patient. The kidney dysfunction seems to be lymphoma related.
Yeah, I just had one question to pathologist, Dr. Rashmi or Madam. How common is anemia in this disease? Because in this patient had anemia. I mean, we discussed all the other causes, but can this disease cause anemia? I mean, bone marrow, of course, you have shown is normal. So I just want to know from a clinician's point of view, it helps in making diagnosis.
But anemia is quite common. I mean, the case reports that are published, most of these cases have anemia and thrombocytopenia also. But why, the reason, though bone marrow is normocellular, is
Possibly it's related to hemophagocytosis, which they are saying occurs in this situation. Maybe the Asian variant. Yeah.
So another question.
Yes, Dr. Joshi.
Yes.
Yeah, the pulmonary thrombus, was it a thromboembolus or was it a tumor thrombus? I mean, the picture that we saw that Rashmi showed, it was a low mag, but it looked rather blue with just a fibrin at the edge. So was that also tumor cells clogging one of the larger pulmonary vessels?
no, ma'am, it was not.
Looked a little blue. No, it wasn't. Okay. So that was a low mag photograph. So we didn't sort of, yeah.
These, it rarely involves the larger vessels, are usually not involved by.
But it looked, I mean, you would agree with me that the entire thing looked blue, you know, so which is not what we see. Yes.
3+ albuminuria in this case must be because of these cells, lymphomatous cells clogging the glomeruli, causing endothelial injury, and always there's a podocyte. Podocytes always kind of reacts to the endothelial injury, resulting in that kind of effaced. It's a crosstalk between endothelial injury and podocytes, which must have led to this 3+ proteinuria, which we are talking about in presence of hematuria also.
So that also puts to question the literature saying that nephrotic is because of minimal change disease. Because podocyte injury itself would cause an effacement of the processes, you know. So you know what I mean. It's not. It's
this podocyte injury became to the endothelial injury basically.
I know.
10 minutes.
Photocytopathy in lymphoma is known. Photocytopathy in lymphoma is known. So
very
that
well.
may be the mechanism in this.
In generally, yes.
Can we?
So I think we can now conclude. Dr. Raja, is that okay?
Yes, sir, perfectly fine. I think, thank you, Professor Ritamra and the panelists for giving us the case, and, Dr. Sakuja, Dr. Kher, Dr. Madam Joshi, Madam Ritamra, Dr. Manoj Jain, and Dr. Mahesha for coming and attending and giving your wise comments. And thank you all for attending this on a Saturday afternoon. It's indeed a pleasure to, listen to these kind of cases, because we are not likely to see them often. Thank you all.
Thank you very much. I think everybody will be looking forward to more of these sessions. Thank you very much indeed.
Thank you.
It's a great
Thank you.
initiative.
Thank you, sir.
Bye-bye.